Hi everyone, I'm Dr. Amir Karam, board certified facial plastic surgeon and founder and creator of KaramMD Skin. I specialize in facial rejuvenation, which basically means I help people look as young as they feel. And I'm super excited to share a very, very cool topic, and that is the evolution and history of facelift surgery. And as a result of this, you're going to be in a position where not only are you going to understand what is out there in the marketplace, what are different surgeons doing, but also, very importantly, what's the best approach for you at this current time? What is the state of the art when it comes to facial rejuvenation and facelifting in particular? And I think it's super important because, man, if you don't get this right, you will regret it, and it'll unfortunately look like a lot of those bad results that we see all over town and in the big cities floating around in the streets that we're like, oh my God, this is the last thing I want for myself. You'll understand why some of that happens and how to avoid them by picking the right procedure for yourself. I'm excited to go into this. Without further ado, let's break it down. So here's how it all happened. Somewhere in the early 1900s, very early on, don't ask me what got into the surgeons' minds, but they decided, you know what? We're gonna try to surgically improve the aging appearance. Primarily jowls, primarily neck laxity, but primarily what was happening in the face. So those early facelifts that were born in the early 1900s basically made an incision along the ear, went underneath the skin, took that skin, pulled it sideways, cut out the excess, sewed everything back up. So what we were seeing is basically a facelift that was skin only and was pulling the skin side to side. What was happening there is there really wasn't a lot of innovation and thought that went into it. And also, to be honest with you, it wasn't, plastic surgery wasn't what it is today. It really wasn't a very, important problem to solve. And it certainly wasn't something that doctors and surgeons were going out and about talking about and sharing their results. And this is something that some surgeons were doing more or less quietly behind the scenes, even if they were plastic surgeons. It was mostly all reconstructive, mostly all. So the first facelifts that were done were skin-only facelifts, all right? This is important to note. For the next nearly 70-something years, nothing changed. Skin-only was the only option that was available. Then somewhere in the mid-1970s, another technique came out, and that was the SMAS facelift. So the SMAS facelift, which is an acronym for something you don't need to necessarily know, but here it is if you want to see what it's all spelled out for. You simply just need to refer to it as SMAS. Everyone will understand what it stands for. But basically, there's a layer below the skin that has a relationship with other muscles in the face that have relationships with other components in the structure of the face. And that if you actually tighten that layer, you're gonna get a bigger and better lift. So keep this point in mind. It's not the skin that ages. In terms of it's not the skin just gets longer and longer and therefore you have sagging jowls and neck. Skin is elastic. So if the fascia gets longer, the skin's gonna get longer with it. Just like it does in pregnancy, just like it does in bodybuilders, just like it does in obesity. It's the fascia underneath the skin that's actually aging. And what's actually happening is from the fascia, which starts at the bone here, and then goes all the way down and connects to your clavicle bone here, that fascia envelops the temporal region, the midface, the jawline, and the neck. And with aging, all of that is basically elongating and crowding down towards the center. All right, so this is really important to understand this because the early facelifts that were done where they were just taking the skin and tightening it here to here, what you were seeing is this accordion-like layering beneath the skin because the skin was tightened but the fascia remained loose. So as a result of that, what you ended up seeing is this kind of like rippling or weird sagging of the fascia against a tight skin envelope. And man, did that look strange. Lips were pulled across, these accordion-like things were going on. It was just not a good look, right? At the end of the day. Then the SMAS came along and then all of a sudden there was like this resurgence, a new birth of interest and energy going towards facelifting. It was like, wow, this is mid-70s. We discovered a new anatomic layer. Let's get after it. Let's do things. Let's make this thing, facelifts better than they had been up until this point. So facelifts started to gain traction. More plastic surgeons were starting to do it. They were teaching it in private practices and academic centers. And the SMAS facelift was the foundation. As a result of all this kind of new energy, other techniques were starting to come into focus. But for at least a decade and a half, SMAS facelift. Now, what does a SMAS facelift functionally look like anatomically? And this is the classic facelift. This is what everyone refers to as the traditional facelift. Incision is made along the ear, skin is lifted. The SMAS, which basically is that deeper layer, it's entered, meaning that you go beneath it. Starting somewhere in front of the ear, you go out a certain distance, 3, 4, 5 centimeters, whatever, depending on the surgeon, you get out to there, and then you pull the thing sideways and you tighten it. So you're pulling the SMAS side to side and lifting it going this way. Now, that accomplished tightening of the deep layer, and then of course, removing of the skin, which is attached to the fascia. Skin is elastic, so skin goes with whatever the structure below it. So if the fascia is getting longer, the skin's gonna follow. So when you tighten up the fascia, you're gonna have excess skin, and that's what you trim off and you remove. But classic facelifts side to side go, from here to here. Now, their primary target is the jawline. Then, there's additional sort of scope of treatments you can do, like a neck lift, and we won't talk about that particularly at the moment, but just know that platysmoplasties and different things like that, where you're tightening up the muscles in this area, removing skin this way, all that stuff was sort of born around the same time. But the classic approach, SMAS. Then we get into the 80s, and all of a sudden we're looking at a lot of different concepts around it. And a particular surgeon by the name of Sam Hamra discovered or elucidated another approach called the deep plane approach. And today we hear a lot about the deep plane approach, but this was a technique that he really kind of popularized, and it never really took off, primarily because it's a difficult procedure. And the deep plane technique, what it does is it enters a layer further down into the SMAS, enters from essentially the cheekbone here, down here, goes beneath the muscles, goes beneath the fascia, all the way out to the nasolabial fold, releases the ligaments in the middle of the face, and still holds the face more or less sideways. But the advantage of that was because there's greater dissection, there's more release, there's less tension, primarily because of the tension that's born from the ligaments that attach the skin and the bone, the zygomatico-cutaneous ligaments as they're called, that attach the skin and the bone here. Once you release that, you're almost tension-free as you release it. So as a result, the lift was bigger, it didn't look as tense and tight. You got rid of all that rippling effect that was down below, more movement, the midface came up, so you got an improvement in the nasolabial fold, and the results lasted a really long time. The challenge was, again, anatomically, it's a difficult procedure to perform. Really, the best of the best and the most advanced surgeons at that time were doing it, which was a very, very small number, probably in the order of 1 or 2% of surgeons in the world who really caught on to this. But we all knew that that was for the big boys. Everyone else was doing SMAS, and the ones who were doing the deep planes were getting lovely results. But they had a larger risk tolerance because the risk of facial nerve injury and all that stuff was considered to be a deterrent for doing the deep plane. As that kind of came up, the other techniques that were sort of born around that same time were the endoscopic technique, where basically, instead of making cuts along here, you go along the bone of the facial skeleton basically, and you release everything at the bony level, and then you kind of like hike everything back up into that direction. So there's a bit more of a verticality to it. There's no skin removal. Oscar Ramirez was the surgeon who brought that to the forefront. That never really quite caught on. That never really quite did. It's a big operation, takes a lot of time under general anesthesia. And since there's no removal of skin, a lot of times people are concerned about relapse and things kind of slipping back to its order. So the deep plane, the endoscopic approach, all around, that same kind of era period, these were innovations of technique, but because of the challenges of performing them, they really never totally caught on. And I think endoscopic, quite honestly, didn't catch on broadly, even among the smaller group of surgeons, because I just feel like the outcome isn't quite the same as you get when you actually remove skin. So that's the idea, the big difference between endoscopic approaches and tightening of the fascia and removing the skin. But timing is very important. Deep planes were a big advance. A couple other versions of the deep plane came out, like the composite facelift, etc., but that became too invasive and too much, so that kind of fell further from the wayside. The next decade or so, 90s, started bringing on essentially surgical techniques that were a little bit less invasive. right? I mean, there was this idea that we discovered the SMAS in the 70s. We went all in on like very invasive surgeries in the 80s between the endoscopic, the deep plane, the composite, and 90s was kind of like, you know what? There's a lot of surgeons creating complications with it. It's, you know, patients are going through this and that, nerve injuries, et cetera, et cetera. There was a whole movement moving towards less invasive techniques. And what are those less invasive techniques? Number one was the lateral SMASectomy, which basically means a strip of the SMAS is removed from here and the face is moved up in this sort of orientation. Same kind of vector for the most part, maybe a little bit more vertical than the deep plane, but at the end of the day, you know, it wasn't entering the deep plane, so it wasn't putting nerves at risk. This was popularized by a surgeon in New York who had a very successful practice named Dan Baker. And his results were very natural looking. You know, people looked great. He had a flourishing practice as a result of it, quick in and out. You know, recovery was easier. Nerve injuries were essentially non-existent. But the caveat was the results weren't lasting quite that long. So 5, 7 years max, people were starting to see looseness starting to come back on a general point. I mean, definitely a lot shorter durability and longevity than a deep plane. In the same era, there's surgeons doing both of them. And I think the deep plane surgeons had the one up on terms of longevity, which is an important thing to keep in mind. Because as a patient, you don't really want to go under the knife too often. You want to see a change and expect to see that change last a long time. But that was a big one. Another one that was very important around the same era was this approach called the MAX technique, which was a suspension technique that lifted all the skin off of the fascia, started a deep suture at the level of the zygomatic bone here, and then wrapped this purse string around this area, and usually sometimes 1 or 2 different purse strings, and lifted the whole face up vertically, brought it up by tightening that loop, essentially, right? So you're weaving this loop through the fascia, then you're tightening it, and it brings the face up. These were brought up by some European surgeons, very natural looking results, you know, overall very aesthetically pleasing. But again, there was this question of durability and all that kind of stuff. But it taught us something very important. Between the lateral SMASectomy and the purse string approach, it taught us something very important, which was that the vertical orientation, because the purse string is almost like all vertical, it really showed a very natural look. And same thing with the lateral SMASectomy. When you're going in this vector, it had a very natural look to the outcome. And so as a result of that natural look, people started to feel a little bit more motivated to get facelifts. They're like, you know, if I could look natural and look like I used to, look more youthful, why not? It's not super invasive. A lot of these were done under local anesthesia, IV sedation, etc. You know, why not do it? So there was sort of a surge of interest in more or less minimally invasive approaches, and more surgeons were doing it, and the results were quite nice. That kind of led to a pendulum continuing to swing in the direction of less and less invasive, and as a result of those less invasive techniques, the mini facelifts were born. And the mini facelifts are essentially techniques that use a small incision around the ear and kind of went back to the skin only, just take out a little bit of skin or put a few sutures in the SMAS to tighten things up, and call it a weekend facelift, call it a mini facelift, call it whatever. And that really took off big time. People were doing these under local anesthesia, etc. But what happened was you realized very, very quickly that those results simply weren't lasting. That went on for essentially, you know, I would say to the early 2000s and 2010, it was happening concurrently with all the non-invasive approaches like strings and you know, fillers and all therapy and all these different things were all happening to basically avoid doing surgery. And mini facelifts were sort of leading the way. It's like, if you're gonna get a facelift, get a mini facelift, because who wants to go through all the recovery and all that kind of stuff? At the end of the day, just tighten things up a little bit and off you go, right? In the office, etc. There was a big company that really made a huge splash in this area called Lifestyle Lift. It has since gone bankrupt, but that concept of this like hour facelift under, you know, local anesthesia, in and out, off you go, was really, really, really popular. And as a result of that pendulum, so remember, we went from basically non-invasive skin only to more invasive in the 70s, got maximally invasive in the 80s with some of these techniques, and then we started to move towards less and less invasive in the late 90s and early 2000s. And then we, like everything else, you look back and you're like, okay, what is going on? What are we seeing in our results? Are we on a right path? Are we doing things right? So as a result of that reflection, what we recognized is that the minimally invasive approaches, mini facelifts, purse strings, smazectomies, etc., aren't quite getting the job done. Number one, they're not lasting quite long enough. Too many people are kind of doing them, like meaning, too many practitioners doing it without really quite knowing what they're doing. And ultimately people are kind of like, I got it done. A year or two later, I look the same. This is, quite frankly, BS. I spent all this money, downtime. I don't want to do this again. They're upset, right? So then what's happened is the pendulum is now swinging back. What you're starting to see again is more invasive approaches. We're starting to realize that you have to get into an elaborate surgical procedure to actually get the results that people want. And what do people want? You want to look natural, you want to look like yourself, and you want to look like a younger version of yourself. And you don't want anyone to know you've had any work done unless you want to share it, right? So that's kind of like the ideal. And ultimately you want to be done with this for a while. In my mind, 10 or 15 years is a pretty good run to have with a facelift and not have to think about anything else. In quick review, we went from more is more, then we went to less is more, and now we're going back to more is more, okay? So here's where we're at right now. Some of the best surgeons in the world are doing deep plane. We see the results on social media, we see the results floating around. The best looking outcomes are generally speaking deep plane today. It makes sense because the best results back in the day were deep plane since the 80s. Some of the biggest names in our industry have always been deep plane surgeons. And sure enough, now we're starting to see that happening again and again. Now, what has been my personal evolution? And this is gonna be a fun little journey. So I got trained in the deep plane, but as a young surgeon, I felt that I wasn't quite ready to do that elaborate anatomic dissection that goes along with the deep plane. So I actually started doing this lateral smazectomy technique that was very popular in the 90s and 2000s, which I took a strip here, lifted everything, combined that with fat transfer, did the work around the eyes, combined that with a lateral brow lift, combined that with a neck lift. And I had a very, very, I would say, beautiful run for about 10 or 12 years with really natural looking outcomes. No one could tell anyone's had surgery done, and very happy patients. My practice grew, I kept out of trouble with complications, etc., and it was great. Around year 10 to 12, I started to reflect on my own results, and I felt that there's two things that were missing. Number one, I wasn't getting after the midface. Midface is the part here that kind of sags over the nasolabial fold. No other technique can address that other than the deep plane. And the other aspect was my results were giving 8 to 10 years or so before they started to look a little less fresh and starting to look like a little bit more worn and unique. So I really wanted my patients to have a strong midfacial elevation, and I also wanted them to have durability. I also came to realize that this entire part of the face ages together. So all this time that I'm telling somebody you need a, back then it was called a short incision, vertical facelift, lateral brow lift, neck lift, I realized that this is all one thing and everyone needs it. There's no one who ages just at the jawline or just at the midface or just at the neck. This is all happening together. And I have a lot of other videos that describe this phenomenon and describe the rationale. But that was where the vertical restore was born. So somewhere around 2017 or so, I began to get my mind, really focused on taking my surgical procedure to the next level, and that's where vertical restore was born. And what is vertical restore? So vertical restore is this. So number one, I'm a strong believer and advocate that in order to look totally natural, totally like yourself, and again, the proof is in the pudding, it's all in the before and afters, you can agree or disagree based on what you see in my work, that this direction, which is what you do in the mirror, you kind of go up like that, this orientation is what gives the best natural result. But then remember, the deep plane doesn't quite do that. So what I wanted to do was combine a deep plane with a vertical orientation, and I wanted every single one of my patients to get elevation in the lateral brow region as well as a complete correction of whatever was going on in the neck. Because I felt like this is all one thing, and it ultimately is what people want to see, is like this all getting better together. So the vertical restore was a vertically oriented deep plane facelift, one that combined a lateral brow lift, mid facelift, correction of the jawline and neck, all in one. Trademarked the procedure because it was a unique procedure, and I also didn't want people going around saying, hey, I'm getting a vertical restore, or I do a vertical restore without really actually knowing how to do the vertical restore, and then diminishing the reputation and the value of the brand of technique that we're doing here. So that's the concept. What I saw as a result of that transition, starting around 2017, 2018, was immediately the results were bigger because I was getting complete release of the mid-face. Elevation all throughout was really shaping the jawline back into that beautiful V shape that we like to see, improvement in the neck, et cetera, et cetera. And patients were actually even happier than they had been in the last 10, 12 years before that, because they're getting even a bigger result. So is the vertical restore a mini? Absolutely not. It's the opposite, exact opposite. It's probably one of the most quote unquote invasive approaches you can take, but ultimately it's one that is worth it, because if you can get durability, longevity, and impact and look like yourself and never look like you've had any work done, it's totally worth it. And you can be free of mind of having anything else done for a long, long time. That's key. And here's the other key piece that you might be wondering, well, when you hit 10 or 15 years, are you gonna just need another one? Not necessarily. It's only if you wanna look literally quote unquote brand new, you'll have another one. But if you never did anything again for the rest of your life, you'll always age much more slowly because you had a properly done lift in the first place. So that result will literally last you your entire life. And that's an important point that was even noted back in the early 1900s, and even with SMAS facelifts, that when somebody gets these done, it changes the way they age in a positive way for the rest of their life. Now, let alone doing something as elaborate and as anatomically complex and comprehensive as the approaches that we're taking today with the vertical restore and other deep plane approaches. All right, folks, that is the entire evolution of facelifting from the 1900s to today in the 2020s. And ultimately, I hope this put everything into perspective. I think the moral of the lesson is ultimately, and this has always been the truth over the last 100+ years that surgeons have been doing facelifts, do your homework, study, make sure that the surgeon you choose is going to do the job that you're hoping for, that this is truly their area of expertise, because that's the one thing that historically has never changed, is the surgeons who focus on these procedures always do a better job, always get better outcomes, and ultimately meet expectations. And today the expectations are higher than they have ever been, because everyone like yourself is visually seeing through social media, etc., what is possible and what can be done, and anything short of that is going to look like a failure. So ultimately, please do your homework. Don't just choose the first surgeon you see. Make sure you're in a position where you feel comfortable and you have the trust that you're going to get the best work done. Now you kind of know where all this stuff fits in. Generally speaking, take-home notes, horizontally oriented approaches, in my opinion, are not the best in terms of looking natural, because that's not what you do in the mirror when you want to do. Deep plane approaches, in my opinion, are better because of the reasons I mentioned. Vertical orientation overall is the key to a natural outcome. All right, folks, I hope this helped. If you enjoyed this, make sure you hit like. If you have any questions at all, drop them in the comments. I will do my best to answer as many as I can. If you haven't already, subscribe to our channel so you get more videos like this down the road, and send this along to some friends and family. Let them be in a position to be able to make good decisions for themselves as well. All right, folks, really enjoyed sharing this with everyone. This is a topic that I really love. It's my specialty. Warmly, Dr. Karam.